What are we learning from COVID-19? I'm Joel Rosenthal, President of Carnegie Council for Ethics and International Affairs, and we're delighted to be partnering on this program with the Berman Institute of Bioethics, Johns Hopkins University. Carnegie Council and the Berman Institute share values, goals, and a common mission. We're both research-driven organizations seeking to generate ethical solutions to global problems. We also place great emphasis on multidisciplinary expertise and the relationships we've built with scholars, leaders, and innovators around the world. So I'd like to begin with a special thank you to Ruth Faden, the inaugural director of the Berman Institute, and Jeffrey Kahn, the current director. I admire both of you very much. As the founder of the Berman Institute, Ruth has shown us the way to do what we do, to ask the hard questions, to explore shared interests, and to develop actionable principles to serve the common good. As her successor, Jeff Kahn has brought to bear his own leading scholarship in bioethics and health policy. He is expanding the Institute's reach nationally and globally to meet the demands of new issues in biomedical technology. I'd also like to introduce our accomplished panelists and thank them for lending us their time and their expertise. Reed Tuckson brings to us years of experience in health policy. He's served as a commissioner of public health and in senior executive positions in academic medicine, nonprofit advocacy, and health systems management. Clive Meanwell is executive chair and founder of Population Health Partners, a global investment firm. He previously founded the Medicines Company, where he was a leader in drug development and healthcare innovations. Nicole Hassoun is professor in the Department of Philosophy at Binghamton University. She is also co-director of the Institute for Justice and Wellbeing and project head at Global Health Impact Project, and was recently visiting scholar at Cornell University. We put in front of this panel an incredibly ambitious agenda, and they've all answered the call, and I thank you again for doing this. And given this very big agenda and the constraints of time, I'm going to hand this over directly to Jeff Kahn, who will chair the session. Over to you, Jeff.
Thank you, Joel. And back to you in terms of thank you for your partnership and willingness to co-sponsor this with us. And thank you for the nice shout out. So thank you to my co-panelists for joining as well. I look forward to a really interesting and engaging conversation. I know we're waiting for Clive to join due to some technical difficulties, so we'll manage that a bit on the fly. Let me do just a tiny bit of setting up and then we'll get right into our conversation. And the way that we decided to do this was not through a series of presentations, but rather really engaging in a discussion among the panelists from the outset. We have broken our time down into three topical areas by agreement. The first will be about vaccine manufacture, production, the process through which we have witnessed the science and the clinical trials and hopefully soon the approval of a new COVID vaccine or a few. The second topic we will take on relates to public trust, willingness to accept vaccination, vaccine hesitancy, and how that might play out both among communities and then globally, and the impacts of that in terms of public health and ethics. And then the third topic we thought we would take on relates to global distribution and allocation. Realizing that there are 7 billion people on the planet, and we need to think about how to manage what is a colossal undertaking in terms of vaccinating the vast majority of those people if we want to achieve the public health goal of beating this pandemic. We hope to do about 15 minutes on each of those topics and then leave a good healthy half hour for discussion from those who are watching. And I know that the idea is for you to all add your questions, comments in the chat. We will have someone behind the scenes doing some filtering and collecting those so that when we get to the discussion portion of our time together, they'll be collected in a way that we can curate them a bit, and we'll engage with our panelists for the last half hour around that. The last thing I'll say before I launch in is that in our pre-discussions about these three topics, we realized that there were really sort of three different elements that we thought were important to address. One is describing what's going on, so a description aspect. The second, a diagnosis, what to do about the things that we identify in the course of our discussion about these three topics. And then the third piece, prescription, what to do about the diagnoses. So I don't know that we'll be slavish to that formula, but that's the way that we had thought about articulating the issues and how to address them. So with that, let's get underway. And I see that we don't have Clive quite yet, so we'll manage that when he arrives. So the first topic relates to the development of the vaccine and its subsequent, hopefully, approval and availability. And I want to start, maybe I'll start with you, Reed, to take this on first, but I know this will be something that everybody wants to talk about. So obviously the vaccines that have come through the process so far have done so in a time frame that is unprecedented for the development of vaccines for human use. So how could that have happened, I guess, is one thing to say. It's the descriptive part, like why has it been 6 months or 9 months, whatever it's been, for these vaccines when it usually takes 5 years at a kind of minimum for other vaccines. And this will, I think, help inform our second topic. What should people be thinking about the fact that we were able to make it through a process and did all the basic science, the clinical research, hopefully through the regulatory process, and get something available for distribution so quickly? What should people take away from that in terms of the process by which we typically do this set of things and have done it this time, and obviously will inform what people think about their willingness to accept vaccination. So I've hopefully given you enough time to get your thoughts together. Let's start with Reed, and then we'll add others. You're muted you're still on mute for a sec.
The most important thing to realize is that the development of the vaccine here did not begin with the first day of the pandemic, that this is a part of a process that has been going on. There were an awful lot of lessons that were learned from the Ebola experience, where we were not prepared back in 2016. And as a result, scientists from around the world, and this is a very important point that we'll be coming back to later, scientists from around the world were collaborating together and planning on how to make a more rapid response. And so they were very fortunate that in their planning, they specifically, scientists specifically said to themselves, how can we be ready? And what they then did was to be able to take a common cold virus that had infected chimpanzees, and they engineered it to be basically a building block against almost anything. And so they sort of had this shell that they could then quickly modify. And so that was very important. And then the next part that was important here was that right at the first of the year, that when the first hints out of China were coming that there was a virus that was responsible for significant spread to people, that got everybody sort of targeted in, and they kind of got involved. The good news actually was that that this was a coronavirus that was doing it. That is something that scientists had great experience with. And so they were able to take that information and then be able to use that with their shell that they had built. And they understood that they had to fight against this spike protein that was a clear target for them. And so that is in fact what happened. So all of that process was very, very rapid because we had pre-existing planning for this moment. We had a pre-existing engineering engine in terms of the vaccine they had started to create, and then they were able to modify that with a disease, a coronavirus, for which they were very attentive to, and they knew something about. And then lastly, they were able to do this because, as you know, that we've been able to run our clinical trials in simultaneous levels of clinical trial statuses, stages 1, 2, and 3, not neglecting them, but running them in parallel as opposed to in sequence. And then the final point is there was a lot of money that was available in the system. And so the economic engine drove it as well. So that is why we've been able to move so fast. And it is important to remember, it wasn't because we started with a standing start among the first case reported.
So great. I think Clive must have just joined. Is that you on the phone?
Yes, it is. I do apologize for being so late. I had a lot of technical problems on my end. I'm sorry.
It's no problem. We'll come to you. You'll catch up, I'm sure, in the conversation. So thanks, Reed, for that. I want to maybe ask Ruth next, and then we'll come to Nicole and back to Clive. So given what Reed just said about the process and how we got there, which seems like in a really rapid manner, all this in the context of a very built up process by which we do regulation and oversight and protection of human subjects in research. It doesn't feel like typical status quo in terms of how this all unfolded, which I think has led to people's feeling like, I don't know whether we've done this in the right way when we've been told all these years before now, it takes a long time and we do this very carefully, and here are all the good reasons why. So maybe you can say something about the regulatory and oversight and human subjects aspects of this, in all put in the context of Reed's really nice framing.
Yeah, happy to. What I'd like to do for a second, Jeff, is just underscore something that Reed said that I think is very important and will resonate when we get to the global conversation later. And that is that the work that Reed was referencing that was done after Ebola, there was this sort of wake up call. Why did we screw up so badly, right? In response to Ebola, why did it take so long? And there was an international effort that was convened and put together, a coalition called CEPI, which was an organization that was stood up from nothing with the intent of sort of jumpstarting so we wouldn't be in this position again. One of the tenets of CEPI is global equitable access to vaccine, right? That's one of its claimed commitments. We'll circle back to that later, but a lot of money poured into this Coalition for Epidemic Preparedness initiative, as Reed was describing. And as part of that process, they took the WHO sort of list of low probability but high consequence threats of emerging and new emerging infectious diseases. And as Reed was pointing out, they conveniently picked SARS-related, coronavirus-related threats as a high priority threat to invest in. Similar things were going in at NIH, so Reed's captured it perfectly, but it'll be later when we talk about this combination, the conversation goes global. We have to go back and think about the roots of the investment were not only national, but global from the beginning, with a lot of money from two big foundations, two big philanthropies, one US and one UK. In terms of the regulatory oversight and the human subjects issues, so everybody worked faster than normal, including the institutional review boards, the ethics review boards. This is not to say that they were cursory, but my understanding is that these trials went to the top of the line for research ethics committees globally. And that cut through for any one of us who's ever been an investigator and knows what it takes. Sometimes you're just sort of waiting for your turn in the queue. This all went to the top of the queue. In the US, existing clinical trials networks that Reed knows so well that were set up for HIV/AIDS were adapted and shifted over. And these investigators and their research ethics committees know well how to work together. So I think that helped enormously in terms of saving time, but not reducing the stringency of the oversight. So again, I can't claim to know, and I think no one could claim to know what went on in every site in every research ethics committee that was engaged in looking at the clinical trials. But I do not have an impression that there were shortcuts from the standpoint of regulatory oversight of the sort that we expect from high functioning ethics regulatory mechanisms.
Great. So maybe the way to capture what both you, Ruth, and Reed have said is there's sort of a new paradigm emerging. right? We did this in a way that was faster, more efficient. We marshaled resources in a way that had been, unprecedented for obvious and good reasons. So maybe to you, Nicole, if that's right, and maybe you can opine about whether you think that's right, what are the implications for how we should be thinking about global health policy, not just for this pandemic and vaccines, but in other broader contexts too?
Yeah, no, so that's, we've seen some amazing things, I think, globally in terms of getting vaccines developed and approved really quickly, but I'm not convinced that, if as the coronavirus kind of surges around the world, for the first time, people who are in developed countries understand what it's like to lack access to a vaccine or other treatments that they really need, right? And that's been a reality for a long time in poor countries, right? And so we have a patent system, a system for rewarding pharmaceutical companies for research and development that rewards them for focusing on the things that usually they can make the most money developing, right? So that will be, treatments often that don't cure but treat chronic diseases of rich patients. And those incentives are fundamentally unchanged. So I think, yes, if we have another global pandemic and a lot of rich people's lives are kind of at stake, then we will see the kind of response that we've seen. But to address, the more fundamental problems of lack of access to medicines and to prepare for pandemics, to address them even more quickly, I think it would be nice to see even more movement in terms of changing our research and development systems so we can reward companies based on the health impacts of the technologies that they develop, so that we focus on saving the most lives and alleviating the most disability. We have this global initiative called COVAX, which helps speed up the development of along with other countries' investments and so forth, speed up the development of the vaccine. It does it through kind of these advanced purchase commitments, the same kinds of things that countries are using to engage with pharmaceutical companies. But we can use that kind of proposal to say, create incentives for companies to focus on pandemic preparedness more broadly, focus on addressing some of the world's kind of worst health threats by rewarding companies based on the health impacts of their technology and not just the prize funds. So not just the profits that they can make by selling to rich consumers. And I think that is it's both a prudentially wise thing for us to do, and then it's in order to be prepared for these other pandemics, in order to address the ones that are threatened to resurge as we get antibiotic resistance and so forth, but also morally the right thing to do. So I could talk a little more about how to do that in the details, but that's kind of what I've been thinking about.
Great, and maybe we'll come back to that, pardon me, and when we talk about global distribution, we can get into some of those more the details. I want to come back to you all, so I'm going to say something that I want you to be thinking about, and the sort of the implications in the way you've all answered the question so far of what's happened with the Chinese vaccine and their implementation to the extent that we understand it, and also what's happening with the Russian vaccine. Clive, before I do that, hopefully you can hear us, and I'm sorry you're having to do this by phone, but I want to ask you about the resource investment piece of this, given your expertise. So I think before you came on, Reed was articulating, the reasons the world was able to make it through what is usually a quite long process so quickly. And one of the answers was lots of resources invested, but those weren't all invested, from across a widespread set of pots of money. Some countries spent a lot of money, and other countries are, waiting to see what happens in terms of access to the things that were produced from those investments. So maybe you can say a little bit about how investment in these areas works and their warping or equitable access creation in terms of what we are going to see next in the vaccine pipeline.
Yeah, thank you, and I apologize for being on the phone like this. I'd much rather be on Zoom. Well, first of all, I think we have to look to our leadership, our policymakers and executive leaders who really set the tone for this. When you learn as an entrepreneurial group, for example, that anything that can't bring data by the 3rd of November is not going to be funded, is a rather a perplexing way for the whole thing to be run, because science doesn't follow those kinds of timetables, even though this particular science got pretty darn close in impressive ways. So I think it has to start with the right signaling to industry and entrepreneurial groups and funders that the stakes are high enough to play in, and that they themselves have, that those stakes are going to be equitably played for, because I think the several companies that I'm aware of have probably set superior technology, not necessarily the vaccines, which are excellent, but for other parts of therapeutics and biologics, antivirals and monoclonals, for example, which will probably be superior to the first generation, which we rushed to. And there's nothing wrong with that. But by saying that the only top-down funding will come for things that can happen in a period of time, I think that's literally short-sighted. So I think we now need to make sure that the momentum of top-down funding from governments to entrepreneurs continues, because in my opinion, scientifically, the best is yet to come. And that's an interesting problem to solve, because picking up the momentum again when we've had such marvelous news on vaccines, some vaccines, is going to be challenging. The second thing is that already I think there are technologies which are being lined up by entrepreneurs and industry groups for pandemic preparedness, which again have been largely ignored. But it's worth remembering that tomorrow, SARS coronavirus 3 could start. So I feel that the rush to November may have impeded some good science. So that's one thing to say. I think the tone is very much set, and I'm not sure this is a political statement, because whoever was making those remarks, it was probably not an easy call at the best of times. But I think tying scientific solutions to a specific date is never the wisest thing, because you never know what's coming along. Science is a somewhat magical process for many people, and timing it is even difficult for those who do it. So I'd say that. Now, is there going to be more demand for top-down money from governments and NGOs? Yes. And if they're able to sustain their enthusiasm, there's already signs, I think, of some dwindling enthusiasm in the last 6 weeks for anything other than buying vaccines. I think that's probably a medium to long-term error. I'm not sure. I think everyone's a bit exhausted. I mean, both literally and metaphorically. A lot of money, a lot of checks have been written, and we'll have to regroup. I hope that the American administration can regroup quickly, and obviously that hasn't been.
Oh dear.
We might have lost you again.
Yeah, I'm sorry. I'm just saying I hope that the new administration can regroup quickly and set priorities again, maybe with a slightly long-term view. I believe G7 will make a real effort next year with the British leadership trying to establish priorities for the medium to long term in a more systematic way. I heard the comments earlier about pandemic preparedness, but that will all require billions of dollars too. So I don't know. I think with the vaccine news, a lot of people have sort of taken a sigh of relief and even a slightly premature, victory lap. But we will have to regroup quickly and come back to top-down funding, but hopefully with a very strategic view this time on a global framework. I think, again, we didn't see the best of global leadership in the last 12 months, in my opinion, and the industry will be opportunistic and will react to what that leadership does. It's as simple as that. I mean, even if you have to go through the World Economic Forum group, which is how CEPI got started, but definitely the industry will follow the money if the money's there. So that money should be strategically distributed. And I'm not sure it has been.
Great. So one thing in the chat that I think I want to remind all of us to do when we use acronyms, CEPI, we've heard a few times. For those who are not part of the global health community, that's a known acronym. So let's spell that out. And I can put some things in the chat with links so people understand what we're talking about. When we say COVAX and CEPI, let's be a little more spelling out. So Clive started to do what I was going to ask you all to do. So now we'll come around. So the Chinese and Russian examples, I think, are helpful for the prescriptive, like what are we taking away from what we have learned about the process, right? So what can we do better? And Clive just answered that from his perspective. World leadership wasn't what it ought to have been, or could have been, or should have been in the context of the development of vaccines. So what would you all say if I were to ask you, what's the takeaway here in a prescriptive way for what we might have done better and need to do better next time? And the Chinese and Russian cases can be examples from which to build. Maybe I'll start with Nicole.
Yeah, I mean, I think there's some criticisms, I guess, particular to the Chinese and Russian vaccines. So global health officials are express skepticism and mistrust of vaccines that are approved quickly or distributed quickly. So it's important to engage in, in the full clinical trial testing process to ensure safety and efficacy of vaccines. We've expedited that, but as you saw in the AstraZeneca trial and some other previous vaccine trials, like with dengue vaccines, there have been adverse reactions in late stages, and so we do need to have that kind of testing and so forth in place. But just to return to the point I was trying to make earlier, I think that this is an opportune moment for us to really think: how do we want to reward research and development globally? What are the good things to get companies and entrepreneurs and so forth interested in pursuing, and how can we ensure that we get early access to other vaccines for pressing health problems that are HIV, TB, so forth, that are still plaguing the world's populations, as well as those that threaten and will probably continue to threaten us in future pandemics. And we want to make sure that everyone has the development of medicines that they need to address the worst health problems globally.
Great. Ruth next, and then Rita, and we're going to then go to our next topic.
Thank you, Jeff. I'm going to speak specifically right now because you asked about the Russian and Chinese vaccines and kind of go back to the global ethics challenges with respect to equitable access, not just for vaccines, but as Nicole rightly keeps reminding us, for much more that is needed to keep people at a point where they can have a decent human life in terms of their health. So we have two countries that have invested heavily in the development of vaccines. The Russian vaccine, a company called Gamaleya, the vaccine I think now is called Sputnik 5. And I have to say that every time I say that, I feel like I want to say the Soviet Union is developing this vaccine, but okay, it's the Russian vaccine. It is a vaccine, the data about which has not been much reviewed outside of the Soviet, there you go, the Russian sort of scientific network. That said, the Russian government is actively shopping their vaccine to a range of middle income countries right now, some of whom they already signed bilateral agreements, we think, but they're not yet publicly known, at least as far as some of us who are watching the space can tell. The Russians have approached the WHO for potential review of their vaccine data. We'll wait and see what happens. But the point is, when we try to estimate something like the size of the numbers of people for whom courses of vaccine will be available, until we know exactly how many doses the Russians are saying they can produce for the rest of the world as well as for their own country, and something about how good their vaccine is, that's going to be a big unknown. The Chinese have multiple vaccines in development. Actually, both the Russian and the Chinese vaccines are deployed widely in both of their countries. The Chinese vaccines, one of which is developed in conjunction with a Chinese-Canadian company, and that particular vaccine has seen the most public scrutiny because it's a Canadian-China joint venture. They are working out and making major commitments with countries around the world. And this is clearly, I'm thinking especially for our international relations, foreign relations participants and audience members, this is an exercise in soft diplomacy at a massive scale that the U.S., as a non-foreign relations person, as I just look at it out the outside, the U.S. is losing an extraordinary opportunity here. And the Chinese and the Russians are filling this gap. Whether the Chinese vaccines are of the quality that we would like, we won't know till we see the data. But I'm going to hazard a guess that there's a decent chance that they're pretty high quality vaccines. They shortcutted in both cases the process that is being followed in the US and Europe and Japan, India, and many other countries. So if we are worried in the US, and we'll get to this, about whether a vaccine that is developed in a short time frame is something that we as individuals should take, and I personally am not, but that's what we're going to talk about next. Certainly, I've talked to colleagues and journalists from countries that are anticipating making available Chinese and especially Russian vaccines, and they're deeply worried about the confidence that the publics there should have in these vaccines, because there the process has been super shortcutted and way less transparent.
So we're going to talk about trust in a second, but I want to give Reed the last word on this topic before we make that switch.
In the interest of time, let me just say that Ruth nailed it. And I want to just underscore just two key points. Number one, I think it is very important to understand the geopolitical issues here and the dangers that are there. Not only the dangers of the United States having ceded a leadership role around the world, which has its own implications.
Yeah.
But I think also the sense that that by combining political objectives with scientific interventions, you start now to really run into a whole series of ethical minefields. Secondly, what is really key that she also mentioned, and it's where we're headed now, so I'll just touch it, and that is there is a real sense that as these vaccines that have not received the kind of testing certification that we would have expected here in the United States, there is the presumption by many parties that these folks who are poorer countries are being used as guinea pigs, and that this is a sort of a way in which people will find out how well vaccines work or their safety in people who are dependent upon the largesse of these donor countries. That sets up a whole set of anxieties in a world where everyone is interconnected and there are no secrets what's going on. What happens in Mali is known all around the world.
Great. So perfect segue to the second part of our conversation. Thank you for that. Thank you all for the interesting answers to our first set of questions. So we're going to talk now about trust and public confidence, willingness to be vaccinated. Should say too, so you all talked about the Chinese and the Russian vaccine. We should also note that the UK medicines regulator approved yesterday on an emergency use basis the Pfizer vaccine. So it's happening quickly. So in all of that context that you've already articulated, we have to figure out how to allocate what we have, but we also have to figure out how to get people who we say should be prioritized for the allocation will be willing to be vaccinated. So just before we came on the webinar, there was a news piece I saw go across my email that Presidents Obama, Bush, and Clinton all have said that they will be vaccinated live on television at the same time in order to instill public confidence. So clearly there's a sense that we need to address this. So I want to do the descriptive part first. So coming back to you, Reed, since I know you spent a lot of time both thinking about and working on these issues, I want to ask you to start answering a question about how we came to be in what seems an incredibly fraught time and moment and situation related to willingness to be vaccinated with this particular vaccine. So obviously there's the whole anti-vaccine hesitation movement. I shouldn't say anti-vax because that's demeaning in a way, But I want to ask you to sort of describe why you think we are where we are before we get to the diagnosis and prescription part.
First, if we sort of look at it generically across the country, you're absolutely right that we've had this movement of people who have been organized against the precepts of vaccination in general. There is a growing distrust across the land in elites, across the board. And we're seeing that distrust of elites in every sector of our society. It extends now into science, so that the word of scientists and the word of trusted officials is no longer accepted as face value by millions of people in the country. Secondly, there is the pernicious effects of social media, where conspiracy theories and all manner of rumor and innuendo with no fact checking becomes the order of the day. And what we find is that there is no longer in America a true north. There's no place that most Americans can turn to have a common conversation on facts. This leads for those who have mischief in their minds, as we have seen through our elections process, and other aspects of our lives. Mischief is now able to be conducted and circulated widely without any checks and balances. Third, the behavior of the President of the United States has been abhorrent, and there is a level of guilt that sits at his feet for having politicized this process that I hope history will judge so harshly as to disavow anyone ever of doing what he has done again. And then finally, you have the specter of people of color who themselves have experienced, with their entire experience in this nation, one of the experiences that leads them to have a distrust of healthcare and distrust of government. And so you add all of those together. The one thing I would just, in the interest of time, just want to underscore, that is the premise of the question. This is not an idle observation. This observation is so deeply entrenched that I fear that the disease of distrust and disinformation may be worse in many ways, or it's hard to battle. Not as because it doesn't lead, but it does lead to death, and it does lead to misery and suffering. But the disease of distrust is so significant; it is almost as hard to fight as the virus itself.
Well said. So Ruth, I want to come to you next, and I know Reed too. All of us have thought a lot about these issues in the context of research on human subjects, and of course, we at Hopkins have a particular context and history. So maybe you can speak a little bit to a little bit of the description about how we have come to this moment and the history that informs the kind of distrust that Reed just articulated.
Yeah, thanks, Jeff. I really liked your analysis, Reed, of sort of identifying these four different streams that are obviously all interrelated. It underscores something I think that is very important to recognize, and that is that the groups of people who are concerned and thinking they will not take this vaccine, it's not one group. They're heterogeneous. They have different histories. They have different value systems. They have different epistemic commitments. They believe different things. One strong focus, I think, that we need to have as we think about this is to recognize that because there are different kinds of people, there are the people who were anti-vaxxers, and I will just use that term here because I think it's fine for some people who were anti-vaxxers before this pandemic and before this vaccine. They have a deep distrust of vaccines and similar related technologies. Those people are where they are. There are the people who are, let's call them newly distrustful of this particular vaccine because they're worried about either the pace at which it went or the administration under which it was developed or some combination. And then, and this is the part I think, Jeff, that you were referencing and that Reed, of course, mentioned importantly at the end of his four comments, there are people of color and there are communities of poverty who have had a long history, horrible history, as Reed has sort of alluded to, that gives them reasons to distrust not only public health institutions and research in particular, but wider American institutions politicians and systems. It's been rigged from the beginning, continues to be rigged against them. So this is the sort of origin of systematic structural injustice, of which structural racism is, you know, the paradigmatic illustration. But it's a rigged system into which poor people and people of color and other sort of oppressed minorities, gender and otherwise, find themselves. And now you've got this vaccine that is being put out there for the African-American community. And I really would rather have Reed speak to this than me, but the African-American community has its own particular legacy with research involving human subjects and with public health institutions generally. You mentioned for us, it's at Hopkins parochially, it's the Henrietta Lacks experience and the experience of her family, which some in the audience may know. Certainly the Tuskegee syphilis study looms large, but there's a term that one of our colleagues has coined of justified distrust. These are communities that are justified in their distrust, and to treat them otherwise, to fail to recognize that they are justified in their distrust is, of course, counterproductive, but also profoundly disrespectful. And so I think it's terribly important that we tease out the different communities of people who are concerned or object or oppose vaccination, and why. You know, there's a different origin story in each of these cases with some overlaps, and the way we respond, and both ethically and programmatically, to these different sources of objection or resistance or hesitancy is very important.
Great. You know, believe it or not, we're flying through this section of our conversation. I want to ask Nicole and then Clive, maybe on a more prescription level. What can we do you think, to reestablish trust? And we've spent, I think, a fair amount of time in this section talking about the U.S. perspective, but maybe to the extent you feel comfortable about it, can speak to this on a more global health level, this part. So what should we be doing to try to reestablish that trust?
Sure. So I'll start with the US. You know, in the US, about half the population is expressing hesitancy about getting a vaccine. The major reservations concern safety, effectiveness, and approval processes of the vaccine. So I think it's important to take those concerns very seriously. We don't want to politicize the problem. And I think the problem of politicizing science lies as much on the left as it does on the right, to accept that kind of framing of science as a thing you can claim. We need to focus on appropriate communication, compassion, listening to people, understanding that diverse populations have differential access to healthcare, and thinking about how we can address these problems. We might think about making sure that people of all racial, ethnic, cultural backgrounds and types basically are included in clinical trials. That's important for scientific validity, but also for encouraging trust in the process. We need to have access to testing and immunization. We need trustworthy community leaders and partners. We need culturally appropriate education, translators, and support for people. Obviously, we've talked about the history a little bit of racism. I think it's important for us to understand that racism is not solely the responsibility of Black people or minorities. It would be wrong to ask these communities just to be more trusting. We need to have, we need to maximize transparency and explain that the purpose of participating in clinical trials is to help improve the health of the people who the trials are, testing, right, the vaccines on, and ensure that they have appropriate support if they do get sick, and that they provide the care for people. I think internationally, it's not quite as bad of a situation. About 70% of participants in one survey I saw globally are hesitant, but a lot will listen to their employers. There's different situations in each country, different groups that might be hesitant. I think we need to have clear, consistent communication with everybody and explain how vaccines work, how they're developed, how the regulatory process works. And then, for instance, the CDC says in the US context, again, when you approach somebody, try to talk to them in a way that makes sure, what you're saying is accurate, that you're credible, that you're empathetic, that you show respect, and that you tailor your message to recipients' needs. And I think all that's really, really sage advice. So that's what I have to say.
Thanks. So Clive, hopefully you can hear us. Your last comment on this section before we take on the global allocation and distribution questions.
Yeah, very interesting comments. I want to just paint a starker picture of clinical trial participation. I've worked with, running ethics programs for people in the biopharmaceutical industry with Maggie Little and other people. And, we've run programs where we ask the biopharmaceutical managers and executives if their grandfather should go into a diabetes trial, and then role-played primary care, investigator, IRB roles so that they can ask all the questions they want to. And in a program of about 860 people, only two finally actually agreed that they would recommend to their grandfather they went in a trial. That's pharmaceutical industry people who actually do have access to all of the information. I'm not entirely sure whether we're as objective as we wish we could be about clinical trial participation, even if we are brilliantly informed, as of course those 800 people were relative to most of us. What I think we're lacking is the love and vulnerability aspects of this, because I don't know about you, but I used to take my cues on healthcare from my mom, who would tell me what she thought I should do. And as I got older, I realized she had some wisdom. And we have to take into account that the community will decide whether or not they take part in clinical trials. I'm very heartened by some of the programs in, for example, hypertension, where, if we are talking about African-American communities, where barbershops have been interesting places to learn different things from African-American, particularly men in that case, getting haircuts and hanging out with their friends and learning things together and discussing them. That is the sort of initiative, if you want to cut through it, we're going to have to go way off the science here and work into those communities with mums and dads, with pastors, with everybody else. I think that anything the idea of watching even wonderful President Obama and President Clinton, and even if they lined up together and had their shots on TV, I think most people would regard that as a bit of a comedy show. That's nothing to do with my life. Of course they're going to get the right vaccine. They're former presidents. I wouldn't trust that.
Mm-hmm.
Johnson.
Oh, I think we may have lost him.
Oh,
okay, we'll wait for Clive to come back, but that may be a good moment to segue to our third topic. We can come back to this, I think, in the question and answer too, since this is a pretty rich area that we didn't fully cover. So the third topic that we identified to cover is global distribution and allocation and prioritization. So this is where the alphabet soup starts to show up. And I put into the chat, hopefully all of the attendees can see, I added some of the acronyms and their meanings and where you can find out more information on their web presence. And I'll do that for the other acronyms that come up. But the way I think best to proceed here, and we talked about this a little bit before, was to start with Ruth, who, for the descriptive part, really can tell us, with Nicole adding on, but Ruth will start, sort of what's going on the global stage, who is leading, how are those groups thinking about global allocation, distribution, prioritization. And I should say, before Ruth takes the stage, that Ruth is a member of the SAGE so-called committee. That's an acronym too that I'll put into the chat, of the World Health Organization, that is charged with making recommendations related to a framework for these decisions from the World Health Organization. So with that, let me turn it over to Ruth to do a summary to the extent that you feel like you can.
Thanks, Jeff. And let me just, a slight correction for my SAGE colleagues. I'm on, with many other people, the working group on COVID-19 vaccines. To SAGE, which is crazy. These are too many acronyms. That is the standing committee of the WHO that opines on all vaccines, and their operation, their sort of way of operating is when a new vaccine comes out, they name a working group to kind of work on the issues and then present them with a slate of options. And then they they make the final determinations, but it's actually the Director General of the WHO who makes the recommendations. So it's sort of like, for those of you who watch the ACIP space, it's like the ACIP working group that then reports its recommendations to the ACIP, kind of a deal. So
immunization practices, that's CDC.
Yeah.
So
sorry. I'm so sorry.
For health policy folks.
Yeah, I really, just, it's terrible. There are too many global and domestic acronyms out there. So in terms of the description, let me just say that, we have a mixed bag here from the standpoint of how this is proceeding. High income countries are by and large have already locked up and have pre-committed or pre-financed substantial supplies of vaccines for their own residents. And I underscore residents because I really, really hope it will be all residents and not only all legal residents, but hopefully all residents of their countries. And so a substantial amount of vaccine supply in the near term has already been sort of bespoken by the US, Europe, Japan, Australia. You can go down your list of high income countries. The Chinese and the Russians are taking care of themselves. And we can go on. And then there are the middle and low income countries. And this is where the COVAX facility comes in. And Jeff has kindly put a little decode of what COVAX is. It gets worse. COVAX is part of something called the ACT Accelerator, which is a global effort stood up by the WHO with support from largely European countries initially to both facilitate the development of not only vaccines, but therapeutics and diagnostics. So COVAX is the vaccine arm of the ACT Accelerator, but it's all three as rapidly as possible and with the aspiration of equitable access globally. So I'm going to just jump 1 second ahead to the diagnosis. And the bottom line is there will not be equitable access to any of these three ways of combating the pandemic. This is really aspirational. And the question is, how close can this global mechanism go towards approximating something that will not be equitable access no matter how you define or whatever your operational definition of equitable is. We won't get there. The question is, will we be better off than before if we had not had this enterprise in place? And the question there is, the answer there is absolutely yes. So with vaccines in particular, the goal was by 2021 to have in this COVAX facility sufficient vaccine to cover 20% of the population of all of the countries in COVAX. Let me just underscore, there are 189 countries as of today, as of yesterday, actually, in the COVAX facility. A chunk of them are not self-financing. They are what are called the Gavi countries. So yet again, another acronym, but they are low income.
I put Gavi in, so that's
perfect. So Gavi is a pre-existing organization that coordinates philanthropic support of vaccine distribution in low income countries. And so there are a preset number of Gavi countries. They are going to be included in the 189 number, and they will receive vaccines essentially subsidized through COVAX with philanthropic support and support of other countries that are participating. Then there's a chunk of what are so-called self-financing countries that are middle income, and a chunk of self-financing countries that are high income that make up the 189. It does not look like this goal of allocating 20% of population vaccine courses to all of the participating countries will be reached by the end of 2021, but it should be reached shortly thereafter. There are Monte Carlo simulations being run now at COVAX to look to see exactly where they're going to end up. I already mentioned some of the wild cards in here. One of the wild cards is what role the Chinese and the Russians will play, particularly with respect to middle income countries. Another wild card is what high income countries will do with vaccine that they, quote, don't need. So this is an ethics hot potato right now. The National Academy's report that Reed was a member of the committee that developed it made a recommendation with respect to excess vaccines. The WHO, the committee that I'm part of, has made a recommendation. The European Union, led by a special group led by the French foreign minister, it's my understanding, is actually working on and has made a commitment that whatever counts as excess vaccines, and that's a very dicey question, right? For the European countries will be donated to the COVAX facility to distribute. In the case of the US, we're going to have to wait for this new administration to see what position is going to be taken. But the US could either, the preferred pattern, I should say, is for those of us concerned with equity, is to have excess vaccines by high-income countries donated to COVAX to distribute through a mechanism that is at least centrally coordinated, but they could go bilaterally. Should underscore that the United States, China, and Russia are not participating in the COVAX facility at all.
China is
sort of. Yeah, China is sort of, but not, clearly. Fair enough, but not yet the way we would like. And the Russians and the US are out. That doesn't mean that they cannot, and the Russians would say they are approaching their responsibilities to middle-income countries and some low-income countries bilaterally. Well, we'll have to see. So another major recommendation for the US and the new administration is that they join the COVAX facility. Now, let me just say one more thing about the descriptive situation. There are a lot of modelers now trying to game out effectively what the impact would be for different ways of distributing out the vaccine that COVAX controls, or just if you imagined a perfect world where a vaccine were able to be developed by a philosopher sovereign, right, in some fair and equitable way. One of the interesting twists in this pandemic, which makes it different so far from other pandemics, is that the burden of disease is greatest right now in high and middle income countries and not in low income countries. This we have not seen previously, at least not in my study of pandemics, and I'm not, a historian of pandemics as some people are, but it's sort of throwing off, right, the way in which we normally say that, when there's a pandemic, the hardest hit are always the world's poorest countries. For reasons that are unclear, at least in terms of health impacts, not necessarily economic impacts, there's been a disproportionate burden of death and disease in high and middle income countries. In part, there is one explanation, and I'll stop here, because of age structure. So because of profoundly unjust background conditions that result in the fact that disproportionately very small numbers of people in very poor countries live to be old, and as they die of diseases that are managed well in wealthy countries, and because the people who die most in the greatest rates from COVID-19 are older, we are just seeing like lower death rates, and in some countries almost nothing at all to speak of. At least they're struggling. They're thinking maybe there's underreporting, but it's still just a different dynamic. So that is a little bit of an ethics head scratcher from the standpoint of how to think about global distribution of vaccine that I'm just laying out there for us to consider perhaps in discussion.
Okay, so Nicole, I'm going to come to you. Two things I want to do first. Cough, but that wasn't the two things. We're getting close to 1 o'clock, but there aren't that many questions in the chat. So please, if you have questions, now would be a good time to send them. We'll keep going because we clearly have more to talk about on this topic, and use our time accordingly. And then I'm going to let Nicole answer, sort of, add on to what Ruth said and maybe do a little more diagnosis, and unless you want to add to some of the description. And then I want to signal Clive and Reed, I want to ask you next, after Nicole is done, to tell us what you think we can learn about what to do in this case from traditional, whatever that means, or historical approaches to distribution, allocation of new medicines, in particular new vaccines globally. All right, Nicole.
Yeah, sorry, give me a second. So, I guess I have a bit more to add by way of description. I think that the most important thing that we need to do is have international cooperation. So there's been a lot of vaccine nationalism. Countries are buying up these vaccines to use for their populations. Canada, I think, has 9 doses per person, and there's a question about what they will do with that capacity. The COVAX initiative is our best sort of global effort to address the problem, but it's estimated that 3 billion people around the world who lack adequate resources like cold chain supplies, immunization camps, healthcare workers, electricity, will lack access to the vaccine for years. And COVAX is by no means perfect. They will let some rich countries vaccinate up to 50% of their populations before giving poor countries more than 3%. So I think, there's a lot of collaboration in there. The World Bank is offering some funding. They're also getting criticized because they may not be doing enough to help. There's limitations that go kind of beyond the immediate distribution plan in COVAX. So the plan, again, is kind of inequitable because it only will give poor countries a little bit first, hopefully eventually up to 20% of the population. And you wonder what happens after that. But even sort of treating countries equally is, I think, not the thing we should do. I think we should focus on helping individuals, and that might mean giving a very unequal amount of resources to different countries, not 20% across the board, because the pandemic doesn't exist everywhere at once. And the competing proposals for fair distribution, I think, are likewise inequitable. I don't think rich countries should get to prioritize their populations first. I think the fact is that we should be supporting poor countries in these distribution efforts. And just to recap from what I've kind of said so far, I think to mitigate the negative health effects of COVID, we need to build better research and development and health systems around the world. So encourage generic production, minimize transactions costs, help countries and companies, tie rewards to the health impact of those investments, and then to address the pandemic and really prepare better for future pandemics, ongoing pandemics. We need allocation principles that require countries and companies to cooperate to increase vaccine distribution, production, and consumption. Countries lack consistent energy supplies, delivery capacity, cold chains, and staff to administer vaccines. Yeah. And there's no reason we shouldn't set up a global distribution system to address this globally and prevent and address, future pandemics as well. So international cooperation is essential not only for producing the vaccines and getting them distributed, but we need all that auxiliary equipment and health systems and health workers to really get it out there. Policymakers and manufacturers need trustworthy and transparent information campaigns to increase vaccine uptake. And we have to recognize that with globalization comes global responsibility. Pandemics just don't respect borders.
So thanks to you both. That was really helpful, I think, framing. Super complicated and obviously a big work in progress. So Clive, I want to ask you now to try to answer, maybe both in terms of what we can take away that's good, and also lessons learned on the not to be repeated, in terms of how we have disseminated, shared, invested in new medicines, especially vaccines, on a global basis.
Yeah, well, obviously, a point was made earlier, which was interesting, which is that the diagnostic capabilities around the world may differ. And I think usually when data are being gathered at this speed, we try to interpret them right away, but it's only later we realize that we may have been using the wrong denominators or the wrong numerators. So I would just caution about whether we know actually just yet how many people are infected or how many people are dying. It's very unclear, and so difficult to set policy on. I mean, all models, which is the alternative way of doing it, are, of course, as George Box told us, all models are wrong. Some are useful, but I think we should be cautious about pre-reading our epidemiology data on the fly, as it were. But the fact of one fact of the matter, though, that's worth considering is that medicines and Coca-Cola are distributed fairly widely by the companies that make them or have distribution agreements in place. And while it's tempting to put the mother of all distribution systems into the world, it might be also tempting to simply bolt together existing distribution networks because this becomes neutral. Whereas the controversies of science and who gets paid and how much money they make are very fair controversies to debate. Controversies of logistics are less alarming. You need to get the stuff. You need to get the stuff to the place, you know, as quickly and safely and under the appropriate storage conditions as you can. And then someone on the end of it, the last mile is always the hardest, needs to be adequately trained. And I really mean adequately trained to stick it in someone's arm. As a physician who's done that quite often, it's not that hard, I can assure you, as many of you know. So, you know, is it possible to teach family members and community leaders how to give a simple deltoid IM injection? Absolutely, with the right type of simple syringe setup. So rather than thinking this is all going to be done through the healthcare system or some clinics or something, we should again, I apologize, I lost this connection earlier, think of this as a community-based problem where families and family trusted community leaders literally have the syringe in their hands because they will be trusted. If my mum, as I said, I hate to come back to that again, if my mum said, stand there, I'm going to give you a shot, I would stand there and get my shot. And I think we need to be very practical. Coca-Cola has learned how to distribute their drink all over the world. I don't know if Coca-Cola are going to be involved in this, but they also know how to distribute chilled things. Drug companies do it all the time. They just have to be asked to do it because I don't think we should make distribution controversial. Now, the top-down question of where it goes, I don't think the industry is in any position to answer. I think that someone has to figure that out, people who are wiser with a broader view than maybe commercial organizations do. So if called to action, I would predict that you would be stunned by the quality of distribution that's available because it's there already. But don't reinvent it. Don't think you have to build it as a public service. Go ask someone to do it for you and tell them to do it for free because now you're working with commercial organizations in their own communities. And that's where they're, should we say, they want to shine their light. So I would be pretty ambitious and fairly optimistic if we could tap into the commercial end here. I do worry, even though I'm very happy about the change of administration, I do worry that because of the cost, the political cost of this change, that there will be a tendency for our administrations around the world, not only here, but in Britain, in Germany, across EU with Macron and so on, to feel they need to distance themselves occasionally from industry for obvious reasons. I really think this is a situation in distribution and logistics where that people shouldn't be afraid of that. That would be the way I would take it on.
Really interesting. And then there was a National Public Radio story this morning about Kroger. I don't know if people heard this, being really good at supply chain and keeping things cold, and that they may well be a place where vaccination happens. And that's a giant grocery chain, of course, in the US. Reed, your thoughts on this sort of what can we take from what we have done before, either good or bad?
I think that what we learn is that there are 5 main categories of things that have to be attended to. Number one, there has to be prior planning. And that I think if we've learned anything, that you cannot start de novo from a standing start. There has to be an infrastructure in place and a pre-planned activity that can be then drawn upon. The transition from the Obama administration to the Trump administration is a perfect example. When an incoming administration ignores the work done before, you have a disaster. Number 2, you've got to have real clear sense of population group prioritization. Which folks are the ones that you go after the most, given the nature of the challenge? And each of these challenges are different. Sometimes pregnant women and children are going to be more important than something else. So you have to be really clear about understanding how do you make those prioritization group challenges. Number 3, you've got to be really clear about the infrastructure resiliency, your supply chain resiliency, and the monitoring of the effectiveness of the supply chain in real time. with particular focus on physicians at the community level and how those will relate to other elements, because it's the community-based infrastructure. If you bypass it, and although I love the idea of the Kroger system, could have significant, and the fact that we're doing all this work now with pharmacies being intimately involved in this, what is the relationship between the pharmacy doing that and the local on-the-ground docs who are competing against pharmacies for their ability to stay in business? And so these are fundamental issues. Number 4, there has to be, we've learned, extraordinary communication at the community level. And there have to be skill sets at being able to communicate information with trusted ambassadors and intermediaries, but also being able to communicate information in ways that people can understand. And then the 5th is the financing of the effort. And the financing of the effort needs to not only include, as we have learned from past experiences, what government puts in, but also how insurance works, both Medicare and Medicaid public insurance, but also private insurance. And one more wrinkle on private insurance is because of the preponderance of employer-sponsored health insurance. What will they do? This came up very much in the H1N1 experience, where we faced such real challenges around whether or not the administration of the vaccine would be a cost borne by the individual patient or by the insurance company or the self-insured employer. So it is all 5 of those elements to me that I think we've learned that they are all important, and each of them will play out in different ways depending on the nature of the threat, except for the first one, which is there has to be in place a comprehensive prior planning that allows you to pivot depending on the scenario du jour.
Great. Wow. Super interesting from everybody. We've got now just a little over 15 minutes for the Q&A, which will, I think, follow on really well. At least I'm trying to curate here a little bit, but maybe picking up directly on Reed's really well-crafted 5 points. There's a question here from Ford Rowan. Ford is a member of the Berman Institute's advisory board and a former journalist, among other things, himself. So he actually invokes a little history too from the H1N1 experience, when in the state of Maryland and led by a group at the State Health Department and at the Berman Institute that Ruth was involved with, and I'll ask her to say more about it in a second here, went through a process of town hall meetings to try to assess the community's feelings about allocation of scarce resources, in that case, ventilators. As you may remember, H1N1, the worry was we'd run out of ventilators, much as we were at the beginning of the COVID epidemic. And so using that method to seek community engagement and community input about the right way to allocate scarce resources when there are just not enough to go around. So maybe not exactly the parallel, but using that kind of methodology to seek public input about how people feel about vaccine safety. So it's a little bit of what Nicole, I think, mentioned in one of her answers. Maybe I'll ask Ruth first to say 2 words more about that effort, since you were deeply involved with it. I only showed up at the tail end of that. So first to you, and then maybe to ask Nicole to weigh in, and then Reed and Clive in that order.
Thanks, Jeff, and thanks, Rowan, wherever you are out there. Thank you, Ford, for the comment and the question. So this was a process we undertook right after the H1N1 scare had sort of passed, and we realized we were not going to run short of ventilators, but we had been doing all of the intense planning, as so many places were, the ethics side, the ICU side, the every other sort of side, to figure out what were we going to do when we ran out of ventilators. Then we never did. And the whole time we were doing this, we were feeling very stressed, because we did not have an opportunity in this sort of compressed period of time to engage with the different publics that make up the state of Maryland and figure out where they were. And we expected to find out that different people would be in different places. So once it was over, and this speaks to Reed, your first point, prior planning, with all good intents, we said, okay, let's not get short-sighted, it's like caught flat-footed again. Let's go ahead and go through this process, which we were able to do I won't go through, we can maybe share the paper and the other papers that have come out since then for others who want to pursue it. It was a very important experience, and we ended up with a plan that was not perfect, which then a group that Jeff was part of for Hopkins took and made better. But the relevance to today, I think, right now, is that while Reed's committee, the NASEM committee, did take public testimony, and he can speak and to the importance of that in your thinking. And I'm not sure what ACIP did. The sort of details, and I'm going to stay with the US for a moment, and then we can talk about this globally as well. The details of what actually are going to happen in terms of prioritization are going to be worked out at the state and local level. And there is still opportunity at the state and local and neighborhood, city and neighborhood and county level to engage with people through a process like we engaged in or otherwise. So for lots of reasons, there are multiple good ethical and prudential reasons for substantial community engagement at this point. It's a heavy lift, but it needs to happen now, and it needs to be resourced, which is a piece of the challenge. I think one way of framing it that some of us have tried to emphasize is that it's been such an important pivot to say we're now going to have science-based policy, but science and the sort of evidence it produces are sort of empirical facts about the world that still need to be mediated by the values that we're trying to accomplish, and in some cases need to trade off in these prioritization sort of contexts. And so if we open up the conversation so that we legitimize the expertise of people who are not scientists, as to say they are just people, right? But they have values, and say those values are really what matters in helping us figure out what to do with the good science, right? So how should we think about this? Is it really right that we should prioritize people who are at greatest risk of severe disease and death over essential workers, or should it be the other way around? I mean, that's not a science-driven analysis. That's got to be sort of informed by the values of the people who are going to be affected by these decisions. So I'll just stop there by saying I hope there's still time, and I am sure that some local jurisdictions are already sort of moving in this direction. And I know, Reed, you're involved in at least one or two initiatives like that maybe you can share with us. But I don't want to go outside of your order, and I know Nicole has thoughts here as well.
We can do it. I think.
Yeah, thanks.
Reed can follow on Nicole.
Yeah, I also have some things to read. So. I mean, I really think the importance of community engagement is something to stress. I'm going to step back to what you said initially, though, Ruth, and you say, I think there's like kind of scarcity mindset. So it'll be an unpopular comment, but that in a pandemic, people tend to think, well, priorities change for doctors and society from individual patient care to maximizing the benefit for the majority, something like the common good, and then we have to prioritize to do that. And I actually disagree with that idea. I think what we should do is respect, you really take those individual concerns seriously and try to respect human rights in that process. And so this kind of shift to utilitarian thinking is a problem for me. And I think what we should do when we face these things, these tragedies where it seems like we can't have enough ventilators, we can't have enough vaccines for everyone, is have what I call the virtue of creative resolve, which is this fundamental commitment to trying to think around the problem, solve the problem, avoid the problem. So rather than spending a lot of time, deciding exactly what allocation principle is right, often we can solve the problem by, getting on the phone and calling somebody at other health systems and borrowing ventilators or sending people elsewhere. So there's this background to this sort of thing that I'm going to say. But with that said, when we do have to prioritize things, because there's going to be tragedies where we really have to decide who's going to get it first, I think it is important to get really clear on those values, to get really clear on what matters. And I don't know to what degree it should reflect the values of the society that holds it. I saw something on the AICP, which is the committee that's deciding how we're going to allocate resources or recommend the vaccine distribution in the U.S. Report suggesting that people do think we should prioritize the elderly, which is not what's the National Academy of Sciences and the ACIP seems to be recommending. And I don't know if that's something that I'd like to hear Reed's comments on. If that mere fact that people seem to have different priorities than the scientists is if there's evidence of that, if that's something that's to be taken seriously. I mean, I think we do need to subject those values to critical reflection. And there are times where if we're really clear about what it is we're trying to achieve, we're going to have the best global health impact. We're going to save the most lives and alleviate the most disability or save the most life years or whatever. If we get clear on our objective, we can often do a really good job of saying, okay, what is it that's going to help us achieve that objective? But I think, you know, there are those times where we need to step back and say, does this respect people? Is this a respectful policy as individuals and not just aggregate, you know, the most good? So I think it's a complicated discussion, I guess is what I'm saying. But I'm interested in what Reid has to say about the way that he is thinking about values, and the ACIP and the National Academy of Sciences are thinking about how values should enter in that discussion, and disagreement, reasonable disagreement about whether we should prioritize the elderly or something else.
Wow. Well, I appreciate the opportunity. I'm not sure how much light I'll add, but let me just throw these out. Number one, I think that one thing that this pandemic is teaching us at this particular moment that comes out of your comment just a second ago is that there is no backup from any other state. Everybody is now maxed out. So, you know, you are really in a bad situation where if your health, if you know that every single state's hospitals are now maxed out, and you can't call in the cavalry from Wisconsin to go help Wyoming, because Wyoming is, you know, everybody's in trouble. But I think the key thing here is, what are the goals? And you just hit it, I think, very much. If the goals is to get people back to work and get the economy going, which has its value. Is the goal to get the schools back open so that the kids can get back? Is the goal to try to reduce morbidity and mortality? Exactly so each of those are different. And so there is going to need to be a clear sense of what are we trying to achieve. Now, the thing that is obvious is going on is it didn't matter, and it doesn't matter that the National Academy made its recommendations, or that the ACIP, that we now know what that anachronism means, that they made their recommendations, because ultimately this is all going to devolve to the states. So the states are going to do what they're going to do. Now, the advocates for people of color or marginalized populations or others will have the NAM report, will have the ACIP report to use as they advocate for changes to a state's decisions that they may make. But what I'm particularly fearful of is that what the states will do, and particularly politicians, will pander to their political base, or they'll pander to the need to show that they're doing well by distributing a certain number in a certain time period. Well, if you're looking for ease of administration and good reportable numbers that say you've injected X number of arms in X period of time, African American and other marginalized communities may not make it as easy to get those numbers as some other communities. And so what you may well find is that at the local level, decisions will be ultimately made that have to do with political expediency or looking good in the media versus the goal of immunizing those who most need to be immunized. And so I am very fearful of what happens at the state level. And lastly, I think that in so many of the states that we have seen, if you look at the election kinds of results and the way in which the activities have been implemented by states to suppress votes from particular communities, I don't think it is a very big leap to think that those elements, those biases, those preconceptions will not enter into the dissemination process for the vaccine.
That again, Clive, any thoughts on this? And it looks like we're going to only have time for maybe this little last bit, unfortunately. Wow, we used up our time.
I'll be very, very brief. I think the comments made are fantastic. I would add only that we should be so lucky. If we've got enough vaccine made quick enough to be able to make these choices and execute them in batting order, I'll be thrilled. But I'm afraid, although we should follow all of these principles, whatever they become as a consensus, we should just get started injecting people. And because this is a global pandemic, frankly, whether it's the upper east side of New York City or the upper east side of Somalia, I think let's just get started. And so I hope we'll have enough vaccine to be smart about it, but I'm afraid we won't for at least a year or two.
So we have 5 more minutes. Let me ask you, I'm going to just try to collect here from among the questions in the chat. A few things related to herd immunity. So like what level of population immunization immunity do we need to get to achieve the public health goal? And what do we think as a group about people relaxing their behavior, knowing that a vaccine is coming, and do you expect a surge as a result? So that's one. Second, about how states will prioritize and whether, when a allocation comes to a state, they get to distribute as they wish, or how will that happen? I know that all 50 states have been required to submit their prioritization plans to the federal government. That's all been done as of middle of last month, actually. So there are criteria within each state. They're not all the same as each other, but they're fairly parallel. What else? Maybe we'll just start with those. Who wants to start?
200 million is probably the number of people that need to be infected and or vaccinated to be able to get to that herd immunity in the US.
Yeah.
So that's a lot.
And we're at 14 million infected now. So, you kind of do the math there. We've got a long way to go.
And the message to take from that is don't relax. We have a number of months yet.
Don't take your mask off. Yeah. Can I just add that some of the latest discussions that I've been involved in are really keen to find out whether these vaccines have any impact on transmission. And if they have transmission blocking potential, you may be able to get away with less people being immunized and still get to something like herd immunity. So that's a global and also, US, any country specific question. But right now, we have no evidence that these vaccines interrupt transmission. So we got to keep our masks on and hope that lots of people agree to be vaccinated.
And that is such a key, I just want to just underscore, that is such a key point. I think that a lot of folks, when we think about and look at the data for effectiveness of the vaccine, we've got to be clear about what individual vaccine candidates are actually, what their attributes are. And that sense of, does it stop transmission versus does it, and also does it reduce severity of illness once infected? I mean, there are several elements of those. And I think that what happens is we start talking about this in the public discourse as if it was just one thing. We've got to be more clear about that. And I'm glad that Ruth brought that up.
I would say too, that stopping community spread. So your answer, Reed, was for the whole country, but of course it will be a locally determined matter too, right? So there's a way of making people's self-interest part of the equation here, right? If you want your kids to go back to school, you want to go back to work. So we need to reach whatever that threshold is in our communities. And over time, that will mean the whole country. Yeah. I see Joel, which makes me think we're trying to wrap up. Is that true?
Well, we're near time, Jeff, but you have some concluding remarks?
I don't, but I think I'm sure others might want to chime in a little bit. Yeah.
I just wanted to say one thing and then I'll stop about the scarcity question. So I think it's really important to underscore that while we're wrapped up and sort of tied up in knots about prioritization within the US, and I'm mindful of your reservations, Clive, it is a big set of assumptions that people are feeling good about that maybe they shouldn't, but at least right now, the projections are that we will have sufficient vaccine in the United States, right? We will have enough. It's just a matter of waiting for when. So when your number comes up, but not whether it might not come up at all. Whereas for most of the world, that is not the operative premise. The operative premise is there will be vaccine in short supply, potentially all the way through to 2024, right?
Or never.
And or never, but it potentially through to 2024, best case, right? Maybe not best case, but possibility. So the point is when people are planning for prioritization in some parts of the world, it's not when, it's ever, like which groups will get vaccine, full stop. So that's a very different context for trying to make these difficult ethics, community values, trade-off decisions, and it needs to be underscored. We're privileged yet again in terms of the nature of our problem.
Yeah. Well, listen, this has been a really interesting conversation for me. I hope for all of you and the attendees, of course. Over to you, Joel, for whatever concluding remarks you might have.
Jeff, thank you very much. And I just want to thank all of you on behalf of the many people who have been listening in. It was a wildly ambitious agenda, and we covered vaccine development. We talked about distribution. We talked about this important issue of trust. And I can see that this is going to be an ongoing conversation. So I hope I can call on you in the future to continue some of these conversations, and crucially to share some of this information with our constituents and a growing constituency of people who are interested and concerned about these issues. And I hope that, you know, the Berman Institute and Carnegie Council can do more of these types of events and perform a public service in that way. So with that, we'll conclude the session. We do sort of live online, as it were. You know, come to our website, the Berman Institute website, lots of resources there, and I'm certain there'll be more coming along the way in the coming weeks and months. So with that, we'll adjourn the session, and thanks again to everybody who participated.
Thank you.
Everybody.